it's time to start our KER Cast, brought to you by the Knowledge and Evaluation Research Unit at Mayo Clinic. And I'm Victor Montori, your host today. And today is a wonderful day. We have extraordinary guests joining us today for the KER Cast. Marleen Kunneman is a doctor in medicine and with a background in linguistics, who's an assistant professor at Mayo Clinic and works as a researcher at the Leiden University Medical Center in the Netherlands. Marleen is a world expert in care that fits through shared decision-making. And it is a wonderful, wonderful pleasure to have you today on the KER Cast. Welcome, Marleen.
Thank you. Thanks for inviting me.
Delighted. As with all of these, love to start by asking you, how does one end up being Marleen Kunneman?
Yeah, I was afraid you were going to ask that. I don't know. So the short answer is I don't know. I guess most of the things that happened and the paths I've been on, I think most of that was, I wouldn't say luck or chance, but it just happened. I think looking back, there definitely are some themes and some interests that I had when I was younger that I still have, and that may have shaped, why I chose to take a certain path. But I don't know. I guess you get to be Marleen Kunneman if you're flexible enough to just take chances and to just walk a path if you see it.
Is this a path that is it a values path? Is it a path of simply what's offered, what's in front of you, or is there something deliberate about selecting a particular road?
Well, obviously there is some. I have a say in it. It's not that I just take every chance that I get. It's I think I've always had an interest in people and in people's health or unhealth, if you can say that in English. I've had an interest in how people interact, how they are when they're together, and I've definitely had an interest in perspectives. So, if you read a book, if I read a book, why do we not read the same? Why do we not feel the same? If you watch a conversation between a patient and a clinician, why do you judge that differently from what I see? So I guess that's always been there. Those are topics that have always, been there in the past that I've walked. So there definitely is some say in what I do.
Is the path towards linguistics oriented or informed by that as well, or how do you end up in linguistics?
There was trial and error, actually. I've had an interest in language. I wasn't really good at it, but I had an interest in it, and I was. Even in secondary school, I started writing quite a lot. So it definitely was something that I was interested in. So I started studying Dutch culture and Dutch language, and then I soon found out that the linguistics part was the part that I was interested in most. And then during that study, I found out that health could be brought back into my studies if I focus more on psycholinguistics and neurolinguistics and clinical linguistics. So that's where I started to do my minors in and started to graduate in.
Phenomenal. You're the only doctor in medicine that is not a physician that I know, and I was reflecting on that, and it's fascinating because it is you have a PhD in medicine itself, you know, in this mysterious ways in which two people come together with a sole purpose of care, right? And it's a very unique area of study versus, you know, the biology and pathophysiology and the treatments and the pharmacology and the epidemiology and the treatment. You know, that would be medicine. You are looking at that caring interaction, and that is the focus of your study. That's why you're one of the preeminent people studying care, you know, the process of making care fit. Did I get it right?
Yeah, definitely. When I did my PhD, I focused on how patients and clinicians can work together in making decisions. So that interest in shared decision making started quite early in my research career. And it's almost like, you know, patients and clinicians need to find a common language, need to find words that we both understand. And if we use words, they should have the same meaning for both of us. So it's almost like when two worlds work together, that you need sort of a pidgin language to bridge that. A language needs to develop when people are working together, and that has really caught my interest. How can you do that, and how can you still care while doing that? Can you even care if you don't do it?
That's fascinating, isn't it? Because it brings a new dimension to making care fit, in that there is almost like a preliminary step in which we learn what you mean when you say that you have this concern or that ailment or that situation. And if I'm trying to offer explanation or respond to your concern as a clinician, I have to do it in a way that does at least two jobs. One is to reflect back to you that I understood what is that you're going through, and that I am ready and able to respond competently and with compassion to it. And there's a whole lot of language that needs to be common for that communication to occur. How do people negotiate that? How do people get to, I mean, in your papers, you talk a lot about dancing, and I suspect that there's a lot of stepping on toes that happens as people are trying to figure out a common language, right?
Yeah, I think so. And I think one of the worst things we can do is that when people step on each other's toes, that we judge, and that we blame them, that it's not good or not good enough. Because people won't learn if we do that. People won't grow. They won't be open to trying a new language, to developing that new language, if we, you know, keep blaming them for what they're doing wrong. And you know, it was interesting, while you were talking, I was thinking about how, you know, we're talking about how to make care fit, and you need the patient and you need the language for that. If you don't have it, you're making medicine fit, or you're trying to make medicine fit, but it's not caring. It's not something that, you know, has the patient's best interest.
Yeah, it's industrial healthcare does that a lot, right? Where you look at the mission and vision statements of hospitals, and oftentimes the word patient is just not there. It's almost like the organizations could exist in the abstract without having to respond to anyone, right? So yeah. The fact that you have to develop a common language implies that it requires the other to be there in order to have that exchange. The other thing that it does is it actually creates a new justification for insisting on continuity of care, because all that effort in develop a common language, and now you have to do it again with the next clinician and again with the next clinician, right? So if you have continuity of care, there's also a continuity of language of care that is born from that, isn't it?
I think so. And, you know, some of the common themes that we hear are, you know, you should trust your clinician. Do you feel trusted by your clinician? And I'm not sure it's really about trust. I'm also not sure whether it's about, you know, becoming friends with your clinician, or it's that sense of feeling comfortable, not having to be afraid that when I say this, how will this land? If I express some anxiety, you know, will the clinician act inappropriate to that? So there is a sense of developing a relationship, and I think that happens through language.
And there's a safety that is created in that, yeah, we might get it wrong, but we'll forgive each other if we get it wrong. And then there is a certain language of comfort that can be developed where you feel cared just in the language that is used and in the language that is not used. For instance, the language of judgment, like you were talking about. So maybe, you know, you can see the direct line between this interesting language and care that fits. As you've gone through this journey, I'm interested, what's been your primary value? What has been the driving idea that you've noticed seems to explain the choices you make?
I think it's, so I don't know if it's something I need before I make a choice, but I think to stay grateful is something that sticks with everything I do, or at least I try. So even if there's a chance that you're not going to take it, then be grateful that you had it. In my research, just be grateful for any chance that you get. Be grateful for your colleagues and for what they can do. Again, it's not about trust. It's not about how I trust a colleague to do something, because that kind of implies that I don't know whether he or she is going to do a good job, but I trust you will. Being grateful is really about having a team and acknowledging, you know, what others can do and what they're good at and what they like to do. Also, in talking about my research, be grateful for what patients and clinicians do. It's very intimate that they let themselves being audio taped or videotaped during an encounter and having these personal conversations about, you know, oftentimes life-changing events. And I get to watch those. So I am extremely grateful for those hundreds and hundreds of patients that let me watch these little stories, these little pieces of their lives, the time they invest in my study. You know, without this, all of my work would not be possible.
It's a huge privilege, isn't it? So as clinicians, when I think of a clinician, I always start by saying is someone with the privilege of the bedside, right? Is someone who has been given access to these incredibly intimate and difficult moments of patients' life, and yet you as a researcher have this, you know, are granted that same privilege by the participants in your research to video record or be present in their visits, which is the way in which you determine the extent to which they develop that common language and they did that shared decision making, right? So gratitude.
Definitely, yeah.
And it's gratitude for the big opportunities, I would think, you know, like the patients seeing letting you see their visits and participate in your studies and complete your surveys and these sorts of things. And I presume it's gratitude also for the opportunity to work with nice colleagues and people that you like and so forth, and be able to present in conferences. And I think the chain of gratitude, I mean, seems like it's essential to conduct this kind of research.
Well, to me it is. I'm not one of those types that looks at a dot at the horizons like that's the place where I want to be. I just want to be in nice places, have, you know, be surrounded by people that I like, and wherever the path will take me, I will at least consider going there. So I really don't know what the dot at the horizon is, but looking back, I am extremely grateful for everything that I've been able to do. You know, how do you become me? I never expected that I would do all this, that I would meet all these people and hear all these stories and really do what I love to do. I'm extremely grateful. So even if everything would end tomorrow, I really hope that I can stay grateful for what happened already.
Yeah, and it's interesting as you mentioned that. I mean, some of the best work I've done, I've had an opportunity to do it with you, and I'm incredibly grateful also for having had the opportunity to this point of doing some phenomenal work with you. That is
Thank
very
you.
good. And it does seem to me that there is also a gratefulness for the little things, isn't it?
Oh, definitely, definitely. And it's not that you don't value the big things, and you definitely also need, some big steps or big compliments, or I don't know, whatever makes you feel good about what you do. But to be honest, there was this one project that I received an award for, and I was very, very happy about that. And at the same time, I received an email from someone I never met before, a researcher from a country that I've never been in, saying, oh, I just came across this article. I just wanted to send you a note that I really find it inspirational, and I have an interest in this area. And I saved the email. I still have the award, but the email, it's such a small gesture. Someone taking the effort of not only reading what I do, but actually reading it to the end, and then sending me an email, probably having to look up my email address too. That really warms my heart. That's really special.
Well, and I made the comment about writing, and I think the kind of response that you got from that email probably speaks also to the kind of choices you make in your writing, right? Many scientists feel the need to use rigorous language and to communicate the rigor of their own science. But I've noticed that you're not afraid of using not only rigorous language and being very rigorous about your research, but communicating that research with language that it's inspiring, and inspires, not only transmits your gratitude, but also transmits beauty. Do you endorse that idea?
Well, it sounds really superficial, but if you're able to make something pretty that's not pretty, then why not do that? Why not try and make it, a piece that has nice sentences and beautiful words and thoughts, and it's way more fun to read in that way. So why not add that joy to the paper if you can?
Usually it's because some editor is going to come in and take it out, right?
Yeah, but then usually you push back and really try second time to get it in again.
Yeah, well,
Doesn't work always, but
it works enough that you can see it in your published publications, right? I mean, that's
yeah. Well, you don't want to know what they took out.
True. At the care unit, we have these principles, right? We like to think of ourselves adhering to these principles of patient-centeredness, integrity, and generosity. We've heard how gratitude is a big driver to you. But which of these three principles resonates the strongest with you?
So if I have to choose, I think I would go with generosity. I think that overlaps with the gratitude as well. But then it has to be sincere. There's no point of being generous if it's not sincere. There's no point of being generous if it doesn't have integrity as well. So you need the integrity, and I really, really value the integrity as well. And yeah, I don't think I can choose. The last, it's all about the patient. Without the patient, we wouldn't have this job. So I cannot say that patient-centered is not important as well. It is centered around the patient. So
center around the patient with high integrity and generosity. So are we missing a value?
The gratitude?
which, yeah, so this seems to me that it will be a corollary of the generosity, is that when others are generous with us, that we feel and express significant, substantial gratitude, genuine gratitude, sincere gratitude.
Yeah. Well, and perhaps even if you're grateful for what is happening, perhaps it makes it easier to be generous. Because I'm already grateful for what there is. So why would I fight to get?
So you have an international perspective on researchers, and you have been very active in mentoring junior researchers in a number of ways. I wonder about this role of values in research. I mean, for us, it's, you know, we put them from the start, and we kept it. But how frequently do you see people make their values explicit, or how important is it in research? And when you talk to junior people, do you bring that up? And when you talk to senior people, do you see them doing so? What's going on in the world in research in relation to principles and values?
Yeah, I think that's a very difficult question. I don't think that we talk about our values or what drives us enough. I think we can definitely do that more. I think working as a researcher, as still, you know, sort of a young researcher, or at least on the younger half of the research field, it is so tempting to just get on the train and get going. And you need more publications, and I want to have more papers and more presentations, and I need to have more money, and I need to have awards. I need to have, you know, stuff to put on my CV and make sure that people notice me. And I cannot deny the importance of that. I cannot, because, you know, my career would stop if you don't care about those things. And at the same time, I really hope that I'm not getting noticed because of those things. And I really hope that, you know, any colleague I help or supervise or work with in whatever way doesn't have that as a primary goal, as the primary, you know, guidance through what we do. Mm-hmm. But to be honest, if I look at, you know, 10, 15 of my closest colleagues, I don't think we actually discuss our values often enough. I don't think we do that. Perhaps it's too vulnerable.
Yeah, perhaps it's too vulnerable. You want to go there? What do you mean by that?
Well, it is, I think it is a profession where you are by yourself a lot. And if you're really into the numbers, if you're really into getting more publications and more money and more grants, then I sometimes get the feeling that, you know, people think about themselves, and then if there's room, then we can think about other people as well. So I think it's vulnerable to actually talk about what really drives me and what I do, which is not the number of publications. But I can't say that, of course, because, you know.
Yeah, it exposes, that's what I mean by vulnerable. You can get hurt by doing that. Well, that's a pity, isn't it?
Maybe. It is a pity. It is a pity. And I don't know if it's specific to our, you know, profession, our field, or whether it's just, you know, how the world can be sometimes.
Yeah. And yet it's such a social activity to the research, isn't it? That if we cannot create, just like in the discussion you just had about patients and clinicians, if we do not create the common language, if we do not open our hearts to connect with each other, which requires us to make ourselves vulnerable, we cannot develop the kinds of collaborations that improve each other.
Yeah. No, I agree. I definitely agree. I think the best projects are the projects where you have an amazing team, and you know, people that you you really look forward to spending more time with them. That you're almost, you know, happy that it's Monday and that you can start working on a project again. Um, and you know, the best collaborations are when you have an interesting, novel topic. To me, those topics need to be, you know, rather big steps. I really don't like the baby steps or the small little improvements. I like to take bigger steps. And you need people that can build together. You need people that can work on something together from their own experience and their own capabilities. And we had conversations on this before, that what I like the most is when you don't sort of start working on the same project and you build one tower and I build another one, and then we kind of make a bridge in between. But I really like it when just you take one brick and I take one brick and we start building, and it doesn't look good. So we start tearing it apart and we start all over, and you really co-create something. It's something that is a product of the team. And, you know, for example, the award that I got, I was the one standing on a stage, but it really didn't feel like my award. It felt like an award we got for the work that we did.
Yeah.
So yeah, those are the best.
Yeah, I agree. That feels lovely. Going back to this idea of being gratitude about small things. I mean, we're taping this in the midst of this COVID pandemic. You are in Europe. Europe is looking at potentially closing things down again in a second wave. You know, we're looking around, wondering what is going on. And has there been a little thing that you're very grateful that has helped you get through this nightmarish time?
That's, yeah, nightmarish time. So that was, I actually think I sent it around to some colleagues as well. There was this podcast, I don't know if that's the right word, on YouTube, where Taika Waititi, so he's a director, film.
That's the Jojo Rabbit guy, right?
Yeah, he is. Yeah.
Yeah.
And he read one of Roald Dahl's books, and he flew in, you know, not literally, but digitally, all these big shots, and it was amazing. I was actually counting the hours until the next podcast would be online. So yeah, I really enjoyed that one. That
so these were famous actors that were reading parts of the story and having a good time together.
Yeah, yeah, and it wasn't just a story. It was Roald Dahl. It's not
about
what's the big deal?
What's the big deal about Roald Dahl?
He's just amazing. I'm a huge fan of Roald Dahl. I think I've read all his books, probably in English and in Dutch. Which is actually interesting, because the reason why I read it in English and in Dutch is because I love his language. I really, really love the words that he uses. I read his children's books, so he has books for adults as well, but I like the children's books the most. He writes for children, but it has so many layers. So it's very interesting for an adult as well. And I think he uses just the right amount of language that we already have to make clear what he wants to make clear. And then he adds on it. So he makes up words, he makes up, you know, phrases or expressions. And then his thinking is so original. So I really love that when you read his books, you feel this, you know, you're not restricted in thinking or in language. I love that.
Yeah, it is. I can't avoid making the parallel between what you're describing, Rodal does for language and lack of restrictions and using the language that is used and expanding on it, and how we, a few minutes ago, described your papers.
Well, I hope so. He is definitely a huge inspiration. And I think it all kind of links, even that I'd rather take bigger steps than small steps, and I'd rather fall while taking a bigger step than having to take a safe small step. I think that all links with this feeling of, I really hope to not be restricted in how I think or how I write when I write, and the language I use.
If you look at your work, what do you say is the meaning of your work? What does it mean so far? Well, maybe we should start with what has been your work, or what's your most exciting work right now, and then maybe think about what does it mean.
Yeah. So I'm going to reverse it. So what my work means is that there's not enough care. That's what it means. If there were enough care, or was enough care, then I would be out of a job, and that would be perfectly fine. So the fact that I'm still working on this means that there's improvement to be made, and it's worth making. I'm not talking about the little steps or about small adjustments. I think there are systematic things that we can do to make care better. So then if I link it to the work that I do currently, the main interest I have is in how patients and clinicians can work together in making care fit. So, actually the theme of today's talk, I'm especially focused on how we can do that in a human way, in a humanistic way. So how can we not lose sight of, I'm a person and I'm talking to a person while I'm caring. And we've done some research on that. We've looked at how often this is addressed in current research, in shared decision-making research, or when patients and clinicians work together, and it actually is almost never addressed. So we're very much focused on trying to take the right steps in the right sequence at the right time. And we're forgetting that while we're doing that, while we're learning to dance, and while I'm learning to take those steps, how can I still, be looking at my dance partner and seeing, who is it? Who is this person? So I think that's very important. And what kind of links to that is the work that we're asking patients and clinicians to do. So what is the work of collaborating in different levels? So cognitive, but also emotional, practical, especially now with the limitations in medium to talk. So what is the work or the burden of participating in shared decision-making? And then I think a last theme that I'm really interested in is that perspective kind of side. So how do we measure this, and how can we measure this in a way that actually makes sense, that doesn't just give us a number, but that gives us information about what is actually happening? Because I really feel that oftentimes we measure and we quantify what perhaps cannot be quantified, and it loses its meaning as soon as you stick a number to it. It's certain things just cannot be quantified.
Yeah, I think that one of your most cited or retweeted papers has been Measurement with the Wink, that makes that case in a very eloquent fashion. But the other aspect of burden, I mean, you're a researcher, and you talked about being grateful to patients and clinicians but there's also a burden of participating in research, that you've been at the forefront of trying to develop this notion of minimally disruptive research, right?
Yeah, definitely. So there's some colleagues that we're working with to try and get a sense of what that burden actually is. And I've noticed in the past, especially when I was starting my career, that it's very tempting to think, oh, let's just add this and let's add that. And oh, perhaps we can look at this as well. And I think, you know, even though it's tempting, we're asking patients and clinicians to participate in this. So we're asking their time, we're asking their efforts. Often these questions are actually quite heavy. You know, it's not, what did you have for breakfast this morning? It's about, you know, are you feeling depressed right now? Do you have any anxieties at this point? Do you feel you trust your clinician? These are heavy topics. So just adding a few more questionnaires, you know, it really has to have a meaning to it if you want to do that. So minimally disruptive research, I think is really important. If you measure it, you should publish it. If you're not going to publish it, then don't measure it. You know, don't measure it for a secondary analysis that you may want to do in 10 years because you're not going to do it.
It'd be nice to have. It'd be nice to have it, right?
We have too much. So we have too much nice to have measures, nice to have data, and we actually, you know, we need to be careful that we don't get stuck in this nice to have or nice to know kind of atmosphere. It's about more than that. If there's something you should know, then you should do something with that knowledge. If you're not going to do the knowledge, then you know, you should kind of reconsider if it's really worth doing, if it's worth asking people for their time and effort.
It is interesting because it configures a notion that you want for care to be in this way, and the research to get you to that point should also manifest the same values, if I may, that you would like to see when care translates your research into practice. Am I getting that right?
Yeah, I think so. What I said, I think it's just really important to minimize the burden of the research for patients, for clinicians, and for researchers. So yeah, I really think that, you know, doing the research it has to be respectful. And, you know, even if they don't complete the whole questionnaire, they tried, they took the effort of starting, and then there was a reason to stop. So
there's a certain kindness in this approach, isn't it?
Yeah, well, there should be. I think there should be.
In research today, there's a strong emphasis on bringing patients and caregivers as partners in the research. And as you were talking about being vulnerable and speaking of one's own values and dreams, there's also a vulnerability at stake when we partner with patients and caregivers, which is we do expect them to speak of their own experiences and of their own challenges and difficulties, and yet we as researchers remain, you know, we have a distance, and we protect ourselves, you know, behind our positions, but we do expect our partners who are patients and caregivers to give. Right, so there's an extension of your idea of vulnerability, particularly pertinent perhaps when we involve caregivers and patients as partners.
Yeah, I think so, and I think a way to kind of, you know, going back to measurement with a wink, we ask patients to participate, but we do it at a point where we really actually know what we're going to do. And what we want to find. And so it is kind of a measurement with a wink. Yeah, there was a patient involved, but no, really, there wasn't. Mm-hmm. And that's disrespectful to their time and to our work, frankly.
We are having a wonderful conversation with Dr. Marleen Kunneman today, and I welcome participants' questions as we move into the last bit of this conversation. Marleen, you've been talking about care that fits, and I'm curious to know what do you mean by fit, and then perhaps what are the features of those conversations that achieve that goal? How do we help people have those careful interactions that then lead into care that fits? What do you mean by that?
Yeah, so I think care fits when it's medically at least reasonable or sensible. And when it doesn't disrupt the patient's life too much, you know, any disease and any healthcare intervention disrupts to some extent. But there's no point of curing a disease or getting better if it's not possible to live during or afterwards. So I think that's the most important thing about Care That Fits. How do we get there? I think we do need a conversation. Perhaps I'm a little bit old-fashioned, but I don't really believe in all new technologies and that we're there yet. I really believe that this is something that we create while bringing different perspectives together, different expertise perhaps on, you know, the medical side and the personal side, on the context of the patient. So yeah, how to exactly do it, I'm not sure yet. I'm working on a project to find out more about, you know, what is Care That Fits? What do we believe Care That Fits is? And when is it relevant? Is it always relevant, or are there certain circumstances where it's more or less relevant? You know, who decides that care fits? Is it up to me to decide as a researcher? Can I observe the fitting of care or the fitness of care? I don't know if I can. So in this project, we're trying to combine different areas. We have a partnership meeting where we invite clinicians and patients and researchers to talk about these topics, and also to form a research agenda for the coming years. We're looking at the literature, what is already there, what kind of, you know, words are used, what kind of things are measured when they talk about making care fit, either using those words or not. And then, you know, going to practice, going to the clinic and observing, videotaping patients and clinicians, and having them look at their own videos and say, you know, where did you get the sense that there was fitting going on? And where did you get the sense that there was a misfit? That the other one was going in the other direction that you didn't expect, or that you thought was further away from you. So there are definitely different aspects that we're working on to get a more scientific feeling or idea of what fit is. You know, other than the feeling that you have.
Scientific feeling seems.
A scientific feeling.
Yeah, it seems like a interesting combination. It's almost like you sort of know you recognize it when you see it, sort of thing, isn't it? But then you're trying to wrap around some rigor so that it could be a reproducible finding. Yeah. Video recording, you've mentioned that several times. Seems, I mean, right now we let essentially every tech company video record almost everything that we do, and there's this anxiety about not being able to hide into someone's private life, because private life is, you know, threatened, and if not, you know, very hard to have. And here's this very private instance of patient-clinician interaction about a medical issue. How do you get to video record? Is it essential? And to what extent do you prevent care from happening because there's this intruder in the room that might be interfering with the process that you're trying to measure?
Yeah, so I think if you really want to look at the language and what is happening, I think observing just gives you the best information, the most reliable information. We can look at what people recall or what people thought, but those are already colored by their feelings and perhaps previous experiences, what they heard before. So if you really want to know what's happening, then I do think that is very valuable to observe. And then you're talking about an intruder in the conversation, but you know, the GoPro is way smaller than I am. So it's easier to get a GoPro in the room and have people forget it than, you know, have me in the room and observe the conversation. Another advantage when I have a GoPro or an audio machine is that, I can have someone else look at it. So it's not just my judgment. It's more, you can try and make it more objective by having other people look at it with, I like to work with people from different backgrounds. So if you have a researcher, I have a background in linguistics, you have a clinician, you have a designer, a philosopher, looking at these encounters, we will all see different things. And this is the perspective that I've mentioned in the beginning. It's the same encounter, but we won't see the same.
Mm-hmm. Mm-hmm. And are you afraid that the presence of the recording device changes the nature of the phenomenon you're trying to capture? Are you afraid that you might be interfering with care?
Yeah, afraid, yes. Do I think it will? I don't know. I think it's good to be afraid of it. It shows that you care. So I think in general, research may interfere. If I ask you questions prior to the encounter and then you're going to walk into the encounter, then perhaps you're going to have a different conversation than when I didn't ask the questions. So yeah, there is some interference probably, but I think that we still have enough to learn to not be bothered by that,
Well, so it seems to me that you're talking about at least two people interacting, and you've mentioned something about maybe feeling a little old-fashioned, that the technology doesn't seem to be doing the same job yet. Again, this pandemic has opened the floodgates for telemedicine. Many places are talking about remote consultations being the default, and then maybe if you qualify because of how sick you are, then you might qualify for an in-person visit, almost making the in-person interactions going the way of maybe house calls have gone away in benefit of office calls because it's more convenient for the system. Yet telemedicine has opened up access to people who are very afraid of exposing themselves to getting infected or going to the medical center, and has turned out to be very convenient for people in terms of being minimally disruptive. They don't have to interrupt their lives. They can just pick up their phone and they have a consultation. Where do you fall on these remote consultations and the possibility of making care fit?
It's different. It's just a different approach, and I don't think it's better or worse, but it's just different. And you shouldn't be trying, to do the same trick in person as you do online or the other way around. It's just a different style, and even if we have to go there for research, it's going to be different. We're going there for teaching as well, and it definitely has some advantages. And some things are a bit harder. So, body language is a bit harder to notice on a camera. So these are things that we would miss, but it definitely opens doors.
Yeah, I've noticed. So I've done now quite a bit. When I take care of my patient with diabetes, I have had now substantially more experience than before with a video visit, and I've noticed an emotional effect on me. So when I have my in-person visits with my patients with diabetes, at the end of a full calendar, I feel energized by the interactions. There's a qualification I want to put in there, because I've noticed that the personal protective equipment and the requirement for the distance in the physical consultation takes, I think, one of the sources that I drew for feeling better about myself at the end of a visit, which has to do with touch. That the restriction on touch, that it has to only be done when absolutely necessary, like when I examine the feet of patients with diabetes, means that when I want to express emotional connection, I'm only left with my muffled words, behind the mask, and maybe the expression of my eyes, but I cannot accompany that with a physical expression, which I recognize as part of my repertoire. But when I finish an afternoon, say, of consultations on video, I'm exhausted. I'm completely depleted. I have a metaphysical explanation as to why that is, but I'm curious to know why do you think that might, I mean, first of all, is that just me and I need to get help? Or is that, do you think that's a general issue? And if so, do you have an explanation as to why that would be?
Oh, that is a difficult one. Because I recognize what you're saying. I don't see patients in person, but I see people in person and I see people online. And it's definitely more exhausting online than it is offline. So no, I don't have an explanation for that. I do think that, you know, coming back to the issue of language, that language is more important if you're online. That, you know, you have to compensate because you cannot touch the patient, because you cannot express empathy in a physical way. Your words count. So how can your words heal? How can your words comfort that patient if you're online? And perhaps making that translation of not being able to use all your qualities, but having to focus and limit to one, and having to expand that one, that just costs energy to do so.
So it's more effort. There isn't this notion of one of the arguments for shared decision making is this notion that we network our brains, that we make decisions together, that we can take different positions in argument, and through argumentation arrive at a defensible way forward that seems to respond to the person's situation. This idea of networking our brains, we assume it's done through language, you know, either verbal language or nonverbal language. My metaphysical paranormal explanation as a rigorous scientist is that perhaps there are other ways in which we network that may involve, for instance, smell, or the transmission of chemical, that there are some chemical signals that we might be emitting that might convey our sense of care, our sense of love, and that we scan it. And my phone, when my phone is in between Wi-Fi signals, it depletes its battery very quickly because it's constantly looking to see what do I attune to, and there is nothing there. And I wonder if the reason why one gets exhausted is one is reaching out to make connection with that human, and it's really hard. It's really hard through the medium. So that's my, you know, once this Zoom technology begins to transmit smells, we might be able to connect better, although that may be profoundly undesirable. So we'll have to see. Is the task then more difficult if the patients are of a different culture? I mean, one of the things that I've noticed is with the advent of income inequality and segregation by class or education levels, that patients and clinicians no longer share the same communities oftentimes, particularly, for instance, specialist consultations, or perhaps more than some of the GPs or primary care consultations. And so there's a bigger job at developing that common language that you talk about, because there's not necessarily a common experience from which to draw that language. Have you ever looked, or are you interested in looking at the issue of care that fits when clinician and patient come from different backgrounds, different cultures, perhaps more obviously speak different languages?
So I haven't personally looked at it. I know some colleagues are looking into that. So it is a topic that's being picked up. And I think it's more, I think it really is more broad than, you know, a difference in language or a difference in culture. Because I think that, you know, even me and my neighbor could be very different. And if she's my doctor and we're going to have a conversation about what to do, we both need to be aware that we're very different, and what is our common ground, and how can we still work together, and how can we develop this language to make it easier to work together. And I think one of the biggest pitfalls is that you're trying to take care of, you know, someone like you. So, you know, someone that you're almost projecting, this person will probably value this because I do, or because I know people who do. And I think that is one of the biggest pitfalls that you can have in true shared decision making, and in truly caring for this patient that is in front of me, and not for groups of patients, or what would I recommend to my parents or to my partner or whatever. It's about this patient in front of me, and probably it's harder work to develop that common language, but it's it should be worth it.
Yeah, but you have 15 minutes, and the computer requires you to click on a few things here before you document your visit, and there's all the people waiting, and please hurry up.
Yeah, that's annoying. No, that's just that's not the way it should be. It's definitely not the way it should be. But how can you deal with that if a clinician takes the time and needs more time, then the clinician is running late and misses dinner with the family, and doesn't get to see the kids before they go to bed. And so it's really, you have to choose between different kind of bad scenarios. So how can we make this easier? Well, by giving people guidelines, or giving people tips on how to work together. And perhaps if people don't see it as doing something, adding something to what they do, but if they see it as, this is my way of having a conversation with someone, then perhaps it gets easier.
Do you have any sense that your work today has changed practice?
I hope it has.
But
it must have.
It better have. So have you gotten a hint? Have you have a sense, or do you have evidence that it has? Because I suspect, you get citations and so forth, so you at least know other scientists are taking a look. But that's not the job, is it?
No, definitely not. No, if it's not being, if patients and clinicians don't use it, through policies probably, then there's no point. I'm not doing research for the sake of research. I think one thing that I can remember, and that was, I was very grateful for, was we did a study where we looked at the information that was shared between patients and clinicians, and especially information on benefits and harms of treatment. And we found tremendous variation in what was discussed. And then the clinicians actually came up to us and said, can we do a consensus study? Because this is not good. We cannot justify that some patients don't get any information about harms of treatment, and others do. So, what do patients need? What do they want to hear? And what do we think they should hear? And can we get to a consensus there? So that was definitely something, that showed me that it was read by clinicians, and that they wanted to act after reading it, after learning this.
Yeah, well, I think anybody listening to this conversation should express substantial gratitude to you, Marleen, for this hour we spent together. We've learned quite a bit about not just you and what inspires you and what propels you and what worries you and what gives you pause, but also how much you add to the task of caring, how much you add to the science of caring, and how when you do it in a way that also makes the world more fun and more beautiful, like like Rodal does when he writes. I think we're all very, very grateful to you for that. And I'd like to finish this KER Cast with a question I like to ask everyone, which is, what's next for Marleen Kunneman?
I don't know. I don't know. I've mentioned before that there's not a dot at the horizon that I'm working towards. As long as I feel that I could potentially make a difference for care, that I can add to care, as long as I'm surrounded by colleagues that have the same feeling and the same value, I will just keep going. Take the chances that you get and just try. The worst that can happen is that you fail and you can try something else.
And maybe when you do, you're surrounded by those friends and colleagues. Thank you, Marleen. That's been a wonderful time. And thanks everyone for coming to our KER Cast, brought to you by the Knowledge and Evaluation Research Unit. I hope you join us next time as well. And until then, please be careful and take care.